next,
Taking in Dr. Aditya first. Probably he has another session. So sorry for that. So Dr. Aditya will be presenting his talk, his paper on. Yes, Dr. Aditya. Yeah, long-term outcomes of implanting EDOF IOLs in pediatric cataract patients.
Thank you. Thank you so much, ma'am. Sorry for barging in. My free paper today is something very unique. It's about long-term outcomes of implanting EDOF IOLs. Just one second. Yeah. So this is the study that we did. EDOF IOLs have been gaining a lot of popularity, especially the advanced monofocals, and in adult cases, they've given repeatable results. So the natural thought came to us is why not imply the similar IOLs in pediatric age groups, because this is basically the main problem. There's a huge gap. The significance of our study lies in the fact that there's no or none research absolutely done for EDOF IOLs in pediatric age groups. There's a big transition where multifocals have been studied and monofocals have been studied, but nothing in between. And of course, we always look for immediate results when we talk about pediatric age group, because you're not only doing a cataract surgery, you're also looking at amblyopia, and that is the main evil that you want to fight. And it actually has real impact through a comparative study, because this is probably one of the only studies which are there at the moment, talking about EDOF IOLs in pediatric age group. Implications of clinical practice, of course, if this becomes in a higher number, as another study or a cross-sectional study is done, this will actually have a very positive implication in all our practices. And of course, quality of life enhancement, that's exactly why we do any sort of surgery in pediatric age groups, is because we want them to see better and live better and learn better. So methodology, this was a single center retrospective observational study, and we needed to compare different types of outcomes when we put a EDOF IOL, the less damaging ones, of course, and enhanced monofocals versus traditional spherical IOLs in pediatric age group. We divided into three groups. Group one was basically more than 10 years of age, where we were more generous with the choice of EDOF IOL. In group 2, we had about 11 young children, and this was between 1 to 10, where we used the advanced monofocal or enhanced monofocals without the rings. And group 3 was the 14 eyes, which we did with traditional spherical IOLs. And there was basically an exclusion criteria of any other sort of ocular condition, like a retinal detachment or anything else that would have made it less perfect. So these were the implants we chose, no financial interest at all. Methodology, again, retrospective review. We did all ethical considerations, took all consents, got all approvals, and did everything in accordance with Declaration of Helsinki. And the basic challenge we had, since it was retrospective, there was limited data, or the right data was not there in certain cases, and those were excluded accordingly. So now this is what the baseline looked like. Most of the group 1, group 2, group 3 that we saw had similar 20 by 200 uncorrected visual acuity was the average. You can see in post-op outcomes, the significant improvement happened post-cataract surgery in most of the cases. But as time went, most of the 85% of the EDOF IOLs actually achieved 20/40 or better, with or without the need of corrective glasses. And enhanced monofocals, about 75% actually end up with 20/40. And traditional, of course, 60% of them achieved, and of course required glasses to get better vision. So statistical analysis, we got to know that the traditional IOLs versus the EDOF IOLs in the older age group, of course, the EDOF IOLs did much better as far as being uncorrected, as well as with minimal correction. And the group 2 showed a lot of better improvement when we were talking as compared to the traditional ones, when we had a minimal glass in front of the eye. But between 1 and 2, there was not much significance statistically. So implication is that it may be a good idea to choose these in an older age group, but still it's a gray zone because the data is very limited. This is something that I thought was very important, is the amblyopia management success. And we saw that group 1 and group 2, that is EDOF IOLs and enhanced monofocals, both had a better recovery as far as amblyopia was concerned as compared to traditional IOLs, which required the standard amblyopia management, which ended up being a slow progressor or slow recoverer as compared to the group 1 and group 2. So the rates went as high as 90%, could be because they were older children, so it was easier to get the amblyopia success in these cases. Spectacle dependence, also the rate of spectacle dependence was much lower when we talked about EDOF or advanced monofocals as compared to the traditional IOLs, and they required a heavier glass depending on the age again. So in discussion, it's actually filling a big void, and their superior outcomes. It is something that there's a big call for longitudinal studies, and there's a lot of future talks which need to be encompassing these set of IOLs. What I like to say is that what seems like the right IOL today may not be so in the future, and that goes both ways. So it doesn't mean that this is the right one, doesn't mean that's the right one, because the child will live long. Thank you so much.
And Dr. Aditya,
sorry. Okay.
what are the disadvantages, any disadvantages in your study?
So the number of patients were very less, so you can't draw a conclusion at all at this moment. But again, in today's world, I think it has to be a cross-sectional study with multiple centers to actually make a difference, because everybody needs to pull in their data. So it's more of a cry of, if anybody else is doing, we'll collaborate our data and make a bigger study. So the biggest disadvantage is limitation of what data we could collect. We couldn't find out the side effects of ring-structured EDOF IOLs like glare and halos in these children, because they didn't complain much as far as that is concerned. But considering that the adults complain less about this, with these IOLs, we've taken that into non-comparative data altogether.
There are issues of, I think in children, they could have amblyopia also. You have to see what is younger and what is
Correct,
older.
sir.
You did not.
Correct. That's why we chose.
That because younger would be a child who is 2-year-old, a child who is 6-year-old. They are also undergoing emetropization.
Yes.
Child who is 10-year-old. They are different set of situations.
Correct.
And
So little biased data is also there when we talk about the choice of age group, because we've chosen EDOFs in older age group, and we've not specified the traditional spherical IOLs. The age group varied.
And we need follow-up also.
Follow-up also.
Then
More
it's a
inclusive
very-
data would actually make a
So
bigger
it is a
study.
very difficult,
Nice.
So as you've yourself pointed out, there was a big confounding bias in this, because the age group was different for the 3 groups you had.
Yeah, ma'am.
And so that is, obviously, this
I think
comparison
that
should have
comes
been in the
with-
same group.
yeah.
And secondly, the thing is, like, you've taken older age groups, obviously, they would have denser amblyopia
denser
if they
amblyopia.
had congenital cataract.
Correct. But they actually did very well. That was the surprising part with EDOF IOLs. The older age group with EDOFs actually
So
did
see,
well.
it means then they were not
But
congenital
again-
cataracts, they would have been development-acquired cataracts.
Correct, correct.
Okay,
So again,
then
it's very
congenital
difficult to
cataract
point.
Not having amblyopia
Yeah.
at that age group, it's unlikely, if it is a significant,
Absolutely.
visually significant cataract.
Thank you.
Yeah.
No, no. Thank you so much.
Yeah, so basically your numbers are very small, no? So saying
Correct.
80%, 75% in very small numbers and saying that is significant is difficult to say. It could just be a difference of one case and
Absolutely.
it could show 5, 7, 10% difference.
But I think that comes with the type of implant.
so I think in the
I
slides-
don't know anybody who's
Yeah,
putting
so that's
large
fine.
numbers with
But
these
I think in the
implants.
slides it's a good idea to put the N also.
Yeah,
with the
it's
percentage that
retrospective.
makes
It's a retrospective study. So.
Sure?
No, no, you
Okay.
can't. No,
Sorry.
it's not allowed.
We need to mention the etiology in this to be able to look at the results.
Yeah. Etiology, unilateral, bilateral, that will also
yeah,
make a
that's-
difference. Yeah, a lot of, it's a big, huge area, I think, so it's a, thank you.